You mentioned a number of trials that are, very informative to this, and Naiyer, I wonder if you could just go over those a little bit more in detail. When should pembro alone be used? There's an alternative of combining pembrolizumab with chemotherapy. Should nivo be used? Is it similarly active in this setting? What do we know?
Right. So in terms of first-line therapy, I mean, I totally agree with Fred that it's really important to have the PD-L1 result up front. I'm sure Ram would agree. And I think that the data is that if you give pembrolizumab first and then you get chemotherapy later, for example, versus if you get chemotherapy first and cross over to pembrolizumab, your survival is better if you get the pembrolizumab first. So I think that that data is really compelling that we should get a biopsy. For our newly diagnosed patients, as Fred said, I mean, the EGFR ALK, those were patients who were not included on the pembrolizumab first-line trial, and it not uncommonly we see patients, with results that come back that are PD-L1 positive and EGFR mutation positive, for example. And I think everyone here would agree that the EGFR mutation result trumps the PD-L1 result, and you should get a targeted therapy.
Yeah.
So I think that pembrolizumab first line in more than 50% positive, which is about 25 to 30% of patients, is clearly ensconced in first line therapy. The chemotherapy combinations I think is a little more controversial, and the data around that is the KEYNOTE-21G trial, where patients were randomized to pemetrexed, carboplatin, and pembrolizumab versus chemotherapy alone. It was a 60-patient per arm phase 2 randomized study, and I think the data are very compelling. That there's a PFS advantage, there is an OS advantage that was updated at ESMO 2017 with a hazard ratio that continues to improve. So I think there's definitely something to the story, but I think for my stance would be that I think there are phase 3 trials which are imminently apt to read out, one being the KEYNOTE-189, which is the same study design as KEYNOTE-21G, and also the IMpower-150, which is the atezolizumab chemotherapy bevacizumab trial. So I think that first-line pembro for sure, the chemo combinations, I think I tend to do it kind of on a bit of an ad hoc basis. I mean, certainly for a patient who has significant disease burden and fairly explosive disease, I've done that a couple of times because the time to response with the combination is faster. So I think that if you're really nervous about the patient, it's reasonable to give them the combination.
Naiyer, can I ask you a question? So KEYNOTE-24 was based on a PD-L1 assay. The chemo combination is for all comers, independent of PD-L1 expression. Would it be currently, with the data we have, would it be a reasonable approach to use for patients with high PD-L1 expression, use pembro as monotherapy, while for patients below 50%, would it be reasonable to offer them pembro and chemotherapy, still under the condition that they don't have another driver? Is that the paradigm which is reasonable?
I think it's an approach. I'm not ready to change my practice for chemotherapy combinations up front based on the small trial that was done. So I kind of do it ad hoc at this point. Mm-hmm. I don't know what others experience.
In that study, admittedly with the small sample size, you don't have the ability to slice different PD-L1 subgroups. But when they looked at the response rate based on PD-L1 expression, in the less than 50% group, the response rate was actually similar, if not lower, for the chemo plus pembro group compared to chemo alone. The biggest benefit was seen for the combination in the highest PD-L1 expressing group of patients. So it's hard to, at this point, make the case that if your PD-L1 is low, you get chemo plus pembro. If the PD-L1 is high, you get pembro alone. And that, again, speaks to, Fred, as you mentioned and Naiyer mentioned, You can only learn so much from a 120 patient trial, regardless of how many updates and subsets you do. We really need to look at the phase 3 trials that hopefully will read out very soon.
Ram, I agree with that, but looking at the trial, weren't there two segments where one was exactly like you say, I think maybe between 25 and 49% or 10 and 49%, and then a lower group where actually there was again a difference in favor. And I know we're dissecting a small trial into too many subgroups, so that it is certainly fair to say the question is unanswered.
Yeah.
But you know, you get into what does this test mean in that setting? Because you know, taking your hypothesis that that is the group of patients that should get chemo and pembro, then you could actually argue, as some institutions are now doing, to not do PD-L1 testing. And simply give everybody the chemotherapy and a PD-1 inhibitor. And you know, I think Naiyer certainly wouldn't go along with that, and I take it, Ram, you wouldn't, and I wouldn't either. So it's really an area of confusion, I think.
And also want to point out that this is all for non-squamous patients. For squamous patients, we don't have data on chemo plus PD-1 or PD-L1 inhibitor at this point.